This is Dr. Sherman. I am going to talk to you about the physiologic adaptations that babies make from fetal to extrauterine life. Knowing these things will help you interpret many of the findings that you see in newborn babies or the first few days of life. But I'd like to point out that the adaptations take place over a period of years, although some of them are quite soon. Some of the stuff you will know, but I may give you a different slant on it. Some of it I'm sure will be new to you. Now, the role of the doctor who follows babies in the newborn's nursery is primarily to make sure that these changes go well. Only in 1 or 2% do they go abnormally to the extent that we have to make some intervention. But over the course of the year, that could translate into 15 to 30 babies. So it is important to monitor these things to make sure that everything is well. So I'm going to start out with the cardiovascular system. In prenatal life, the fetal circulation is characterized by a right to left shunt. Most of the venous return to the right side of the heart bypasses the lungs. There's enough blood flow to the lungs for organ development, but because the lungs are not participating in gas exchange, they don't need the entire systemic circulation. The blood flows through the ductus arteriosus and the foramen ovale. The ductus, of course, the blood goes from the pulmonary artery into the aorta. In the foramen ovale, it goes from the right atrium into the left atrium. Now, those are simply anatomic channels. The reason blood flows from right to left is that in utero, pulmonary artery pressure is much higher than systemic pressure. This is the only time during life where that's normal and healthy for that to happen. Because of pulmonary arteriolar constriction, these resistance vessels in the lungs are constricted in the presence of hypoxia, and that causes a pulmonary blood pressure to be quite high. Now, a large portion of the systemic flow goes to the placenta, but not all of it, certainly. You have blood flow to the kidneys, to the arms and legs, to the brain, to the eyes, and that blood goes back into the systemic venous return, but bypasses the placenta. Therefore, you can consider that there is a shunt past the placenta. No matter how good the placenta is in oxygenating the fetal blood, you have an admixture with deoxygenated blood in the venous return to the right side of the heart. And the baby is saturated at 65 to 70%. Now, by definition, that means hypoxia, although the baby is not dysoxic because of some other adaptations that we're going to talk about in a few minutes. Postnatally, the lungs expand, and they're exposed locally to oxygen within the alveoli and respiratory airways, and that increased oxygen tension in the lungs causes dramatic and massive pulmonary arteriolar vasodilatation. So the pulmonary artery pressure drops like a rock. Simultaneously, the ductus begins to constrict. Oxygen dilates the pulmonary artery bed. It constricts the ductus. And so the right to left shunt diminishes, not only because of ductal constriction, but because the pulmonary artery pressure drops enough that there's no longer a driving pressure from right to left. The umbilical cord is clamped within a few seconds or a minute or so of birth. That increases systemic vascular resistance dramatically and increases systemic blood pressure. As soon as the systemic pressure equals or even exceeds pulmonary artery pressure, the shunt goes away or it reverses. Babies do this normally, and we look for and see a 90% saturation at 5 minutes of age and a 95% at 20 minutes of age. It is impossible to have a significant right to left shunt, breathing room air at atmospheric pressure, and have a saturation of 95% if there is any significant right to left shunt. Now, the ductus, under the influence of the oxygen, typically closes at around 24 hours of age. So the consequences of all of these adaptations is that the baby squeezes down on the resistance vessels to the hands and feet and sometimes the face, but it remains centrally pink while it's cyanotic in these areas. That's called acrocyanosis. That increases the systemic resistance and increases the systemic blood pressure, decreasing the shunt. That's a normal physiologic adaptation that typically goes away in 24 hours. When we do screening for congenital cyanotic heart disease, in particular for ductal-dependent lesions, we measure the saturation in preductal blood, typically in the right wrist, and in postductal blood, one of the 2 feet. And we want to see a difference of less than 3% or 3% or less between those two. Now, you need to not have much ductal blood flow for that to happen, and so we wait until after 24 hours to decrease the false positives. Our goal for this congenital cyanotic heart disease screening is at least one of these values is greater than or equal to 95%, and that the difference between the 2 measurements is equal to or less than 3%. That would be a pass. Frequently, we hear fairly harsh murmurs on the first day. This is probably caused by ductal blood flow. Don't really call this a patent ductus arteriosus because that implies some pathologic condition. Patent ductus arteriosus at 3 or 4 or 6 months of life, you have to do something about that, and we consider that very abnormal. So while this is ductal flow, I like to avoid the term patent ductus arteriosus and just call this a transitional murmur because it's occurring during this transition from fetal to adult circulation. And typically these murmurs will go away after the first day of life. Because the pulmonary artery and systemic arterial pressures are relatively equal early on when you're looking at the child, small VSDs are typically not heard. That's because there's not much pressure differential between the left and the right ventricle. However, as right ventricular pressure drops and left ventricular pressure rises on the 2nd and 3rd day, these small VSDs are commonly heard. And this is probably the most common murmur that I hear in the newborn nursery, typically very high-pitched, early systolic murmur that I completely did not hear on day 1, but appears on day 2 or day 3. I'm going to talk a little bit about pulmonary changes. The terminal units of the lungs are in connection with the amniotic fluid and contribute to it, not only volume, but some of the constituents. So when we measure an LS ratio in the amniotic fluid looking for evidence of lung maturity, we're measuring surfactant that's produced in type 2 alveolar cells. These cells live in the bronchioles, very small airways, very deep in the lung, but they get out into the amniotic fluid because that fluid is in continuity with the amniotic fluid. Most amniotic fluid is from fetal urine, but the lungs do contribute a small part of it. When babies have a biophysical profile to assess their well-being in utero, we often see diaphragmatic movement, and that produces a little bit of in and out of amniotic fluid into the baby's mouth and upper airways and out. But there is not deep tidal breathing, and that amniotic fluid is not sucked way down into the bottom of the lung. Now, during normal labor, the membranes rupture, the entire baby gets squeezed, and we see evidence of that with head molding, but the thorax as well gets squeezed. And because the amniotic fluid is now coming out, when the baby gets this Heimlich maneuver, it empties a large amount of the lung fluid out. And so when the baby is born following a normal vaginal birth, the lungs have lost a lot of their fluid. When the baby inflates the lungs, the small amount of fluid that's in there is rapidly reabsorbed into the interstitium, and within about 20 minutes, the lungs have attained their normal state of dryness. The babies have normal pulmonary mechanics, and that's part of the reason, along with the reversal of the shunt, that the saturation gets up to 95%. Now, with a non-laboring C-section, there's no Heimlich, so that they have retained lung fluid, and it can take up to 48 hours for these lung units to dry. This is sometimes referred to as transient tachypnea of the newborn. It is most common with a non-laboring C-section. So a woman has had a prior C-section. She elects to have a C-section for the next pregnancy. She's not in labor, they do a C-section, and the baby has some respiratory distress for some hours after birth because of retained lung fluid, or what we refer to as transient tachypnea of the newborn. Now, it is not only seen in that circumstance. Even babies born vaginally can have it. It's just less common and less likely. Some babies undergo a lot of labor before they're born. Some babies are born when the mother says, well, I had about 3 contractions and the baby was born. So those babies clearly are not squeezed quite as significantly. Let's talk about some of the hematologic changes that we might see. In prenatal life, babies have primarily fetal hemoglobin. It's alpha-2, gamma-2. So there's not a beta chain, it's a gamma chain. There are advantages to the baby of having fetal hemoglobin. It has a high oxygen affinity. It facilitates transfer of oxygen across the placenta into the baby. And at around 28 weeks of life, it is essentially all of the hemoglobin that the baby has. The beta chain becomes progressively activated or methylated, and by about 40 weeks of gestation, 10% of the hemoglobin on average is adult hemoglobin, alpha-2, beta-2. Now there's enough of that so that on the newborn metabolic screen, when the state lab does a hemoglobin electrophoresis, they can inform you as to whether or not the beta chains are normal. But there's little enough beta chain that if a baby has an abnormality of the beta chain, such as beta thalassemia or sickle cell disease, those diseases are not manifest in the newborn baby, but are manifest later on when the baby switches over to making primarily adult hemoglobin. Now, I mentioned already that the saturation in utero is 65 to 70%, by definition hypoxic, but the baby is not dysoxic, is not suffering consequences of a low oxygen saturation. If you think of hemoglobin as a bucket that carries oxygen to the tissue, then the baby is compensated by making lots of buckets. And so if you have twice as many buckets that are all half full, you deliver the same amount of oxygen as if you had your buckets all the way full but a lower hemoglobin, and that's what babies do. They are born with hemoglobins of 17 to 20, much higher than at any other time during normal life. It turns out that the fetal red blood cell has a fairly short half-life. Adult red cells live about 120 days. For the red blood cell, the half-life is about 50 days. The consequence of this is that the baby has to make a lot of red blood cells to replace those that are dying and to keep the hemoglobin in a healthy range. So the babies have a retic count of about 5%. That's the upper limit of normal for a retic count for a newborn baby. Now at the tissue level, you have to unload that oxygen. So babies have high levels of 2,3-DPG and have some tissue acidosis. Both of these things shift the oxygen saturation curve to allow unloading so that the baby is able to utilize this oxygen at the tissue level. And evidence that this works well is the fact that these babies are rapidly growing at a rate that's very high compared to after they're born and developing quite well. Now, we've already said that the saturation gets to be 95% by 20 minutes, and so the baby's body says, oh my goodness, look at all of this oxygen. I had enough before, but now I got enough for a couple of people. And so the oxygen delivery to the tissue is greatly increased, and the juxtaglomerular apparatus of the kidney does not sense any need to make more hemoglobin, and so EPO levels rapidly fall, and the reticulocyte count rapidly goes to 0. 5% retic count means a very active, metabolically active bone marrow. The baby decides it doesn't need to use all of that metabolic activity. It can go to different purposes, and it isn't going to continue to do that. Because these red blood cells have a natural senescence with a half-life of 50 days, over the next 6 to 8 weeks, the hemoglobin slowly falls to a level of about 10.5. At that point, the baby's body begins to sense the need for more oxygen, and it turns back on, and the baby will stabilize with a hemoglobin of 11, a retic count of 1 to 2%, and those are normal values out to about 2 years of age. During this quiescent period, the 6 to 8 week period, the beta chain activation is now completed, and when the bone marrow turns back on, the cells are primarily filled with adult hemoglobin. And it is at this point that the beta chain abnormality can become clinically apparent. So with sickle cell disease, for instance, you need about 70% of the hemoglobin within a cell to be sickle hemoglobin for that to crystallize and to cause a sickling of the cell and then vascular occlusion. So it's really around 4 months of age that babies have enough of these red cells to block up the small blood vessels, and they develop bone infarcts and splenic infarcts, and at around 6 to 7 months of age become functionally asplenic. Beta thalassemia would also become symptomatic at this time, particularly if it's beta thal major. Now, because alpha chain is expressed even in fetal hemoglobin, homozygous alpha thalassemia is essentially fatal to the developing fetus. So, again, we will see adult hemoglobin at birth for the newborn screen, and if the baby has sickle cell disease, the pediatrician will be notified of that, although the disease itself doesn't become apparent for some months. Now, all of that hemoglobin from these dying red blood cells is released, acted on by heme oxidase, and becomes unconjugated bilirubin. This bilirubin crosses the placenta, goes to the mother conjugates it, and excretes it for the baby. However, with birth and clamping the umbilical cord, that mother's dialysis unit essentially doesn't work anymore, and the baby is stuck with that unconjugated bilirubin. Because glutathione transferase is not highly expressed in the fetal liver or at the time of birth, and in particular in babies that are preterm, it's not as expressed, the bilirubin simply accumulates at a relatively constant rate until the baby, sometime in the second or third day, begins to start conjugating it, so the rate of rise slows, stabilizes, and then the bilirubin begins to be excreted faster than it's being produced. And at around 2 weeks of age, the bilirubin will fall to usual adult levels. This causes jaundice. These babies are often jaundiced on day 2 or 3 at the time of discharge, and we are not very concerned about it. We might see a bilirubin of 8 on day 3 and say, well, that's in the low-risk zone. That's not a problem at all. An adult with a bilirubin of 8 would be having a liver biopsy to find out why they were so sick. But we understand this in children. We call it physiologic jaundice of infancy, and we really don't worry about it very much. If that physiologic jaundice is a little bit more than normal, and it exceeds some line that we have said, well, I really don't want it to get any higher than that, I'm going to start phototherapy. Well, it's still physiologic jaundice. It's just now accentuated physiologic jaundice. However, if the bilirubin is being produced much more rapidly because of rapid turnover of cells and release of a lot of hemoglobin, then the rate of rise of that bilirubin will be much faster, and within the first 24 hours of life, we're already around a phototherapy threshold. That is highly suggestive that there's a hemolytic disease going on, and one should look for that. Now, I won't argue that you should never get a CBC and a retic count in jaundice at 2 to 3 days of age, but I will say you should always think about hemolysis if you have high bilirubins within the first day of life. So, hemolytic diseases of newborns can have a number of different etiologies, and we see all of these almost in the newborn nursery. You can have membrane defects such as hereditary spherocytosis and elliptocytosis. These are typically chronic, low-grade hemolytic events, but often enough to trigger suspicion because of early rise of bilirubin. There are some ion transport proteins, sodium-potassium pumps, and if there's an abnormality in them, you may develop hereditary stomatocytosis, also one of these fairly chronic low-grade problems. Sepsis causes hemolysis almost always. in the worst case, the babies have frank DIC. But even without frank DIC, hemolysis almost always accompanies sepsis. And we certainly see that in the newborn nursery, although more commonly in the neonatal ICU. Enzyme deficiencies, G6PD is very common worldwide, and there are a number of different isotypes of G6PD deficiency. Some of them are much more manifest in the newborn period and lead to high levels of bilirubin very early on in children. These tend to be more of a problem in the Eastern Mediterranean and in some parts of Asia than they are in the United States. Although we do see hemolytic events that we can't otherwise explain in the newborn nursery and think that these children need to be followed to see whether or not they have one of the G6PD variants. Pyruvate kinase can be a very severe hemolytic disease problem with tremendous elevations of retic counts and elevations of bilirubin to the point that children can actually die from this in utero, although in other children it seems to be a relatively mild problem. The major thing that we think of in hemolytic disease of the newborn is an isoimmune, where the mother makes an antibody to some antigen that's present on the fetal red blood cell causing hemolysis. The most severe of these is usually the anti-D, which is the Rh antigen. So the mother is Rh negative, father is Rh positive, the baby's Rh positive, the mother's been sensitized, and the baby gets hemolytic disease from this maternal antibody that's transferred across the placenta. We can also see a similar kind of problem with ABO incompatibility, and we do antibody screens in pregnant women to see if they have antibody to other red blood cell proteins, Kel, Duffy, little c, and the blood bank can often tell you whether this is likely to be a problem for the baby or not, but we will frequently look for evidence of that antibody attached to the baby's red cell. All right, so here's isoimmune disease in the Rh negative woman. So she does not have the D antigen on her cell, therefore she's Rh negative. But if she has been sensitized to this from a prior pregnancy or some other event, then she will have antibodies directed against the D antigen. So the baby is now born and is Rh positive. The presence of the Rh factor or the D antibody is an autosomal dominant. So if the father is Rh positive, he will have at least one of those genes, and the baby may get it, have a red blood cell with abundant D, and because the mother has lots and lots of this antibody, it will be bound to the D antigen on the surface of the baby's red blood cell. So in the laboratory, we do a reagent called the direct antiglobulin test. This is also called a Coombs test, and we find evidence of this, and so the lab will say, well, that baby is DAT positive. These antigen-antibody complexes also bind to the Fc receptor, which is on the surface of macrophage cells in the spleen called Kupffer cells, and when they detect that, they take a bite out of this membrane. One bite, perhaps you have a spherocyte. 2 bites, perhaps you have a disrupted cell, and that's the hemolytic disease. So this baby would be DAT positive and would have hemolytic disease because the Fc receptor is detecting that and lysing these cells. The baby is going to respond to this hemolysis, which is taking place in utero, by making more red blood cells. So if the half-life of this red cell goes from 50 days to 25 days, then the baby has to make twice as many red cells to keep up with that to maintain a normal hemoglobin, so I might see a retic count of 10% with a normal hemoglobin. But if the hemolytic process is really florid, the baby may not be able to keep up with it. So we have seen retic counts in the range of 15% with babies who have low hemoglobins, and then if that hemoglobin is low enough, the baby heart rate has to go up to increase cardiac output to try to maximize oxygen delivery, and then eventually the baby falls off the curve and goes into heart failure, develops peripheral edema or hydrops fatalis, and that can be detected on an ultrasound. If it's thought to be because of isoimmune disease, that baby may undergo an intrauterine transfusion with Rh-negative blood and may have early delivery and potentially need an exchange transfusion to try to get rid of these Rh-positive cells. These children have a very early and dramatic rise in bilirubin and require intensive phototherapy or additional therapy to try to control that. With ABO disease, it's a fairly similar process, different proteins. The mother is type O, which means she doesn't have A and doesn't have B. Now, unlike the woman with Rh disease who has to be sensitized by some blood, everybody who is type O has antibodies to A and B. These proteins are commonly found in nature. They're on bacteria, they're on foods. So a baby who's born with type O blood is sensitized quite early and has these A and B antibodies. Now, the blood bank doesn't report them. So the mother may be O positive with a negative antibody screen. Well, they don't report anti-A and anti-B because everybody knows if she's type O, she has anti-A and anti-B, so they don't need to report that. But you need to know that they have them. So the baby's type A. But when we look at that baby, in this ABO incompatible situation, 85% of the time, these babies are direct antiglobulin test negative, and there's no evidence of hemolysis, no early rise in bilirubin. If we measured their hemoglobin and retic count, it would be completely normal. About 10% of the time, they are DAT positive, but still have no hemolysis, and it's only about 5% of these babies who are both DAT positive and have hemolytic disease. Well, why is that? The blood bank tells me this is a type A cell. I know she's got type A antibody. Why in the world would this be true? Well, it turns out that the fetal red cell poorly expresses the antigens of the ABO system. Now, there is biologic variability, so some of them have more than others. And this situation where they're DAT positive with hemolytic disease, presumably those red cells just have enough so that they have some hemolysis, although it is typically much less severe than in Rh disease. But adult red cells have lots of type A on their surface. Fetal red cells don't. And so that explains this problem. And it pretty much doesn't matter whether it's type A or type B blood. Now, I have seen one case of ABO incompatibility where the mother was type A and the baby was type B, but that's actually quite unusual. My guess is it has to do with the titers of antibodies that are produced. If you're type A, you probably don't make quite as much anti-B as you do if you're type O. For infants who have an OA or OB incompatibility and the positive DAT, so that's this 10 to 15% here, we follow transcutaneous bilirubin closely, about every 6 hours. If they have significant hemolysis, we're going to see a rapid rise in the bilirubin, and then we can further evaluate them and institute early phototherapy to try to control it. These children are not usually anemic and usually don't have really dramatically elevated retics, although on occasion you see an ABO incompatibility that has fairly severe hemolysis. All right, I'm going to switch focus here and talk about fluid balance in the newborn baby. So we have a scenario here with a baby whose birth weight is 3 kilos. Now, for reasons that have to do with stool hydration and insensible loss and some other things, maintenance fluid calculations for a newborn baby are 60 milliliters per kilogram on day 1, 80 per kilo on day 2, and 100 per kilo on day 3. Those are just maintenance. Now, what does maintenance mean? It means that you're maintaining something. What are you maintaining? Hydration status, electrolyte balance. Maybe we stick some sugar in there to have for its protein-sparing effects. But if somebody is on maintenance fluids, you would expect that their weight isn't going to dramatically change. That's what maintenance means. So this baby, this 3-kilo baby, will have maintenance requirements of this. Now, when a baby is breastfed, fairly careful measurements show that a very healthy baby, a healthy mother, baby latches well, nurses well, gets only about 25 milliliters, not per feeding, but for the entire first day of life. And that isn't quite as good on day 2, probably goes up some. Let me just estimate that it goes up to 50 mils. By day 3, it really depends on where she is in her lactogenesis cycle, but we'll leave that alone for the moment. But you would expect that if that's the maintenance requirement, and that's what the baby is actually provided, that the baby is going to lose weight. And in fact, that's what happens. The average weight loss on day 1 is 3 to 5%, on day 2 is 6 to 7%, and often on day 3, we see children in the 9 to 10% range. Not every day, but it is sometimes. So this happens very commonly, but how do we interpret this data? Well, a 10% weight loss in a 1-year-old is moderate dehydration. So a mother brings a baby in with a history of vomiting and diarrhea and not eating, and on examination, you found the baby's mouth to be dry and perhaps some elevation in heart rate, and the baby is lethargic, and you're worried about that, and you start an IV and put them in the hospital and calculate their fluids, and when you do that, you estimate their deficit for moderate dehydration to be 10%, or if it's severe dehydration to be 15%, and you're treating that baby aggressively. But this baby on my service is 10% dehydrated, and when I go in and look at that, he's got a moist mouth, had urine output within the last couple of hours, is hungry, maybe hungry and angry because he really is hungry, but is otherwise normal. He has no clinical signs of dehydration at all. Why? Why would a newborn baby look so good at 10% and I send him home, maybe with early follow-up, but I send him home, and this 1-year-old with the same amount of weight loss, I'm putting in the hospital and treating with IV fluids? Why is that? Well, it turns out there is an explanation. Infants have about 10% of their body weight as extra fluid and electrolytes. It's a reserve to carry them through the time of relatively small volumes of breast milk. Babies are designed to be breastfed. Breasts are designed to feed newborn babies. They are a matched set. Now, if I had designed the system, maybe I would have made breasts that produced a lot of milk on day 1, but I didn't design this system. So the designer of this system designed babies who have 10% extra to carry them through the period while their mother's milk is coming in. Weight loss during the first few days of nursing is expected, and it's healthy, and it's not evidence of starvation. If you tell mothers about this, your baby is going to lose 3 to 5% on day 1, 67% on day 2. Your baby will not be all that hungry on day 1 because they got all of this extra on board. They're not that hungry. Your baby isn't rejecting your breast to feed the baby. The baby isn't starving to death. This is normal. By day 3, your baby will have lost this reserve, and they will turn into a ravenous beast who won't leave you alone. If you do that, the mothers laugh about it on day 1, and then they're much more comfortable in this process. Now, we're talking about women who don't have experience of breastfeeding. But you can really increase the rates of breastfeeding babies if mothers know about this ahead of time and are responding to it appropriately. Now, if the baby has lost most of that reserve, most of that 10%, then we do assess the situation. And the lactation consultant may go in the room and say, oh, not to worry, the mother's milk is in, she's got lots, the baby is nursing beautifully, and I can hear it swallowing. So the weight loss is going to stop, and I don't have to worry too much about it. Or they're going to come out and say, ooh, she still doesn't have any milk at all. I've taught her to supplement, and I've taught her in a way that isn't going to inhibit the baby breastfeeding, and we should follow this baby fairly soon. But I've taken steps not to treat dehydration, but to prevent dehydration. Dehydration is the first or second most common reason for hospital readmission for infants discharged from the nursery. We can avoid that if we recognize that the baby is at some risk of that and address the situation with the mother. If you're 9 or 10% down and we are supplementing for some reason and I have any concern at all about it, then I'm going to want that baby to have an early follow-up visit. That can be at the primary care provider's office, or it can actually be done in the hospital by the lactation service. They have an outpatient clinic where they can do that. So lactation is incredibly useful for this assessment and for help in the follow-up plans. Now, pediatric nephrologists sometimes refer to newborn babies as edematous and state that they diurese during the first 2 days. In actual fact, I don't think they're edematous. I think they have reserves, and they're not diuresing pathologic fluid. They're using it to prevent dehydration. So these are healthy babies. Now, another takeaway from this is that if a mother is bottle feeding her baby, and the baby is only designed to get 25 milliliters a day, that really translates into about 5 milliliters per feeding. Now, mothers will often say, oh, my baby's eating so well. He took 45 mils on his first feeding. Well, if you keep that up, the baby's going to be vomiting, and then they're going to tell you that they're allergic to that formula and they need something else. Overfeeding bottle-fed babies on day 1 and 2 is extremely common. And the typical weight loss for a bottle-fed baby is about half of a breastfed baby, and they regain birth weight by 3 to 5 days instead of 7 to 10 days. I'm not so sure I regard that as an advantage to these children. It certainly is not the way that the babies were designed to be fed. All right, so what are our routines in the nursery that have anything to do with this? Well, we weigh them every day. We measure and talk about their percent weight loss. We expect it. We want to make sure it's within the parameters that we are defining as normal, and we want to respond to it if it if it looks like it's putting the baby at some risk with an appropriate assessment and plan, and we need to document that plan in the discharge summary. We do daily transcutaneous bilirubins. It's a non-invasive screen of the baby. Every night when they're brought in for their weight, they get a transcutaneous bilirubin. We have graphs to interpret that. We expect physiologic jaundice, but we respond if that jaundice rises too early or too much. We do congenital cyanotic heart disease after 24 hours of life because we expect the ductus to have closed by that time. We do a type, an RH factor, and a direct antiglobulin test for babies born to mothers with type O blood or mothers who are RH negative. Not only are we looking for isoimmune disease here, but if the mother is RH negative and has an RH positive baby, then she needs to get passive immunity, RhoGAM or Rofalac, to prevent her from being sensitized. We have little concern for murmurs, even if they're pretty harsh sounding murmurs, in a very well-appearing infant on the first day. And we listen very carefully on subsequent days because that's when we'll begin to hear murmurs that indicate some pathology. Infants discharged from the hospital before 2 midnights, this is regarded as an early discharge by AAP recommendations, need an exam the next day. Why? Because there are all these physiologic changes that are taking place, and while 98 to 99% of the babies are going to march through all of these without any help from us, there is that 1 to 2% who will need some help with one aspect or another. So one of my requirements for an early discharge is a 1-day follow-up appointment, and I ask mothers to make that before I write the orders to discharge the baby. So those are the things we do. Now you know why.